My name is Brian Hummel-Price. I am a PGY3. Thanks for joining me today. We will be discussing our project, which is in progress, titled Don't Blow It on O2 Optimizing Oxygen Therapy in COPD Patients. The primary author on this is Daniel Kang, PGY1, and Stuart Kano, PGY2, assisting, as well as myself, PGY3, and Dr. Mustiller, our attending representative. So essentially, COPD remains a leading cause of hospitalization and acute respiratory failure, and often requires supplemental oxygen therapy treatment while inpatient. While oxygen is essential in the treatment of hypoxemia, excessive oxygen administration in COPD patients with chronic hypercapnia can lead to worsening respiratory status and increased morbidity. In contrast to the general inpatient population, where target peripheral oxygen saturation is usually greater than 93%, patients with moderate to severe COPD are optimally maintained within a lower target range of 88 to 92%. This strategy mitigates oxygen-induced hypercapnia, respiratory acidosis, and subsequent escalation to mechanical ventilation or significantly more invasive ventilation practices, regardless. The pathophysiology of oxygen-induced hypercapnia is multifactorial, including VQ mismatch, Haldane effect, suppression of hypoxic respiratory drive. Recognition of these physiological principles is essential for improved inpatient management and potentially decreased hospital length of stay. For the aim statement for this poster, the aim of this project is to evaluate whether adherence to strict oxygen saturation targets of 88 to 92% in hospitalized patients diagnosed with COPD exacerbations associated hypercapnia are associated with reduced hospital length of stay compared to higher saturation targets. Specifically, this project will assess whether implementation of controlled oxygen therapy correlates with decreased incidence of oxygen-induced hypercapnia, escalation of respiratory support, and overall improvement in patient clinical outcomes. So here's some of our infographics, but essentially for our metrics, we used oxygenation target adherence, whether or not there was an increase percentage of time that patients stay within the target range of 88 to 92%, whether or not that improved hospital length of stay and decreased rates of treatment escalation as indicators of therapy optimization and patient safety. And then also, we wanted to see whether or not we were able to increase the proportion of patients with a documented median saturation within the target range of 88 to 90% during hospitalization. For this, we gathered retrospective observation chart review of patients admitted with acute COPD exacerbation requiring supplemental oxygen. We assessed patient demographics with appropriate inclusion-exclusion criteria, provided education at the multidisciplinary level, aka we had meetings with different levels of nursing staff and respiratory therapists. We use EMR and visual cue-based intervention with laminated cards, literally just a card printed on laminated paper that was hung in the room by the oxygen tree. And then we reviewed the data regularly and provided interdisciplinary team feedback monthly as needed to note the improvement. The importance of this project is that it evaluates a low-cost, high-yield systems-based intervention designed to improve adherence to evidence-based oxygen saturation targets at the point of care. The intervention aims to reduce unwarranted hyperoxia, enhance consistency in oxygen delivery practices, and potentially decrease hospital length of stay, escalation of care, and prevent preventable complications among patients hospitalized with this acute COPD exacerbation. So in figure 1 here, this is our kind of before intervention target from the whole calendar year 2025, essentially from January all the way to January 2026, which was when we were closer to implementing our changes. So the number of patient days by median SpO2. So initially we had obviously quite a large percentage of median SpO2 days greater than 92. So clearly something had to be done. And as you can read here, it says pre-intervention hospital length of stay, mean hospital length of stay for COPD exacerbation periods prior to implementation of intravascular demedication. Reminders was approximately 6 days. And then in figure 2, this is kind of the start of 2026 when we started to actually implement these changes. We found a reduction in average hospital length of stay was observed following implementation of targeted oxygen titration, education intervention, and bedside visual reminders, suggesting potential improvement in adherence to COPD oxygenation targets and downstream resource utilizations as we were able to get a lower overall proportion of SpO2 patients in the higher SpO2 range. So we were able to actually successfully increase the ratio of patients that are in the goal of 88 to 92%, which ended up increasing, decreasing overall length of stay, allowing for decreased utilization of hospital resources overall. So, of course, getting patients out of the hospital faster with COPD, as long as there's less overall readmittance rate, or readmittance rate is the same, would yield improved overall outcomes. And that's kind of what we're seeing so far. But overall data is still pending for completion. Thank you for your time. Bye.